Stable liver disease after care. Liver disease in pregnancy. Here are the key points summarized from the article. 1. Common serious hepatic complications during pregnancy include HELLP syndrome, hemolysis, elevated liver enzymes, low platelets, acute fatty liver of pregnancy AFLP. 2. Early referral to a liver unit is essential for pregnant women at risk of hepatic failure. 3. Poor prognostic indicators in pregnancy-related liver disease include lactate, 2.8 mg/dl, presence of encephalopathy. 4. Regional anesthesia may be considered in mild, stable liver disease after careful risk-benefit assessment. 5. Liver disease in pregnancy, while uncommon, can lead to significant maternal and fetal morbidity and mortality, requiring anesthetic planning especially during delivery or HDU admission. Hepatic physiology in pregnancy. Normal pregnancy causes hormonal changes, estrogen, progesterone, that affect liver biochemistry. Transaminases, upper limit decreases by 25% in all trimesters. ALP, increases in the third trimester due to placental production. Postnatal period, transaminases and GGT increase. Clinical implications, normal signs like spider nevi and palmar erythema can mimic liver disease. Advanced liver disease shows broad LFT abnormalities. Always consider differential diagnoses. Presentation can be misleading. Hepatic disorders specific to pregnancy, HELLP syndrome and AFLP are major hepatic complications in pregnancy requiring ICU care. HELLP, 7%, AFLP, 3%, HELLP syndrome, a severe variant of preeclampsia, affecting 4 to 20% of PET cases. HELLP is not always associated with preeclampsia, typically presents in late third trimester or postpartum, can even present within 48 HRS of delivery. Maternal mortality 1%, but high contribution to overall maternal deaths. Managed in HDU due to unpredictable progression. Clinical features, hepatic angina, epigastric ruck pain, nausea, vomiting, may mimic pulmonary embolism, chest pain, tachypnea. Mild hypertension, proteinuria, low platelets must be monitored. If platelet count less than 50K, severe disease. DIC in 20%, acute renal failure more common than in typical PET. Complications, acute kidney injury, placental abruption, liver hematoma, pulmonary edema, intracerebral hemorrhage. Management of HELLP, stabilize mother, timely delivery of fetus. Definitive treatment, delivery of the placenta. Steroids do not affect disease course but may be used to promote fetal lung maturity if delivery can be delayed. Delivery mode depends on maternal status and labor feasibility. Urgent C-section may be needed in severe cases. Coagulation concerns, central neuraxial block CNB may be contraindicated. Consider both platelet count and rate of decline. HELLP, stabilize mother, timely delivery of fetus. Definitive treatment, delivery of the placenta. Steroids do not affect disease course but may be used to promote fetal lung maturity if delivery can be delayed. Delivery mode depends on maternal status and labor feasibility. Urgent C-section may be needed in severe cases. Coagulation concerns, central neuraxial block CNB may be contraindicated. Consider both platelet count and rate of decline. Perform a clotting screen in all cases. Cross-match blood products. Be prepared for major hemorrhage. Support with blood product replacement as needed. Invasive monitoring is clinically indicated. Recovery typically begins within 24 to 48 hours after delivery. LFTs usually normalize before platelet count recovers. Complications of HELLP syndrome. Watch for complications, acute kidney injury, placental abruption, liver hematoma or rupture, pulmonary edema, intracerebral hemorrhage. Platelet transfusion only if actively bleeding or before invasive procedures and DIC. Manage complications accordingly. Note, RUQ pain in HELLP warrants urgent imaging US, CT, or MRI. Liver hematoma rupture, rare but serious mortality 16 to 60%. Often presents with shock. Managed with interventional radiology or surgery. Acute fatty liver of pregnancy AFLP, rare condition linked to preeclampsia, often presenting in the late third trimester. Pathophysiology. 1. Abnormal mitochondrial fatty acid oxidation. 2. Inherited deficiency of LCHAD enzyme. 3. Accumulation of long-chain fatty acids and hepatocytes. 4. Microvesicular fatty infiltration and hepatocyte failure. Genetic component. 1. Autosomal recessive disorder. 2. Often associated with heterozygous mother and homozygous fetus. Clinical features of AFLP: high maternal and perinatal mortality rates. Signs and symptoms. 1. Presents after 30 weeks gestation, often near term. 2. Prodromal illness, 1-2 weeks, with right upper quadrant discomfort and malaise. 3. Abdominal pain, anorexia, nausea, vomiting. 4. Features of preeclampsia, mild proteinuria and hypertension, in approximately half of patients. 5. Jaundice and ascites may develop. 6. Coagulopathy, hypoglycemia. Diagnosis: diagnostic challenges due to similarities with HELLP syndrome and other liver diseases. Clinical diagnosis aided by Swansea criteria: 6 or more signs. Symptoms: radiological imaging, MRI, CT, ultrasound, may show hepatic steatosis, but findings can be inconsistent. Liver biopsy is gold standard, but reserved for unclear cases due to coagulopathy risk. Complications: fulminant hepatic failure, coagulopathy, hypoglycemia, renal impairment, pancreatitis, adult respiratory distress syndrome, ARDS. Laboratory findings: 1. Elevated transaminases 3-10-fold, and alkaline phosphatase. 2. Hyperbilirubinemia. 3. Marked hyperuricemia. 4. Hypoglycemia. 5. Coagulopathy and DIC may occur. Management: severe cases may need ICU management. Multidisciplinary approach for timely decisions. Expedite delivery after stabilization of more correct hypoglycemia and coagulopathy, if active bleed. Monitor for other associated complications, occludic liver hematoma, etc. Careful postpartum management due to potential worsening of symptoms. Anesthetic concerns: correct coagulopathy before delivery. Regional anesthesia may improve hepatic blood flow, but coagulopathy may preclude its use. Obstetric cholestasis, impaired bile acid excretion in pregnancy, causes pruritus, typically affecting hands and feet. Pruritus can be severe but rarely requires hospital admission. Vitamin K malabsorption may occur, requiring assessment of coagulation before regional anesthesia. Consider potential for underlying liver disease, e.g., AFLP or hepatitis. Anesthetic considerations: balance benefits and risks of neuraxyl opioids for pain control versus potential worsening of pruritus. Hepatic disorders incidental to pregnancy. Hepatic disorders not directly related to pregnancy are less common but can cause significant maternal morbidity and mortality. Pre-pregnancy counseling: women with severe liver disease should receive pre-pregnancy counseling. A. Viral hepatitis. 1. Most common cause of hepatic dysfunction and jaundice in pregnancy worldwide. 2. Types: hepatitis A, B, C, D, E, G, herpes simplex virus, HSV, cytomegalovirus, and Epstein-Barr virus. 3. Hepatitis B affects 350 million people globally. Vertical transmission can be reduced with active and passive immunization. 4. Hepatitis E, worse course in pregnant women, higher risk of fulminant hepatic failure and mortality. B. Autoimmune hepatitis. 1. Generally improves during pregnancy. 2. Management: immunosuppressive therapy, e.g., azathioprine, cyclosporine, tacrolimus. C. Drug-induced liver injury. 1. Consider drug-induced liver damage if cause is uncertain. 2. Common culprits: paracetamol, methyldopa, antiretroviral therapy, estrogens, and progesterones. D. Cirrhosis and portal hypertension. 1. Rarely become pregnant, but high mortality rate, up to 10%. 2. Increased risk of variceal bleeding, decompensation, ascites, and hepatic encephalopathy. E. Liver transplant. 1. Favorable outcomes with normal liver function and coagulation. 2. Continue immunosuppression throughout pregnancy. F. Budd-Chiari syndrome. 1. Hepatic venous outflow obstruction. 2. Presents with ascites, hepatomegaly, and right upper quadrant pain. 3. Pregnancy is a risk factor for thrombosis. Management of liver disease during pregnancy. 1. Individualized care plan with multidisciplinary team. Mountain Daylight Time. Input NHDU2 care. 2. Early liaison with nearest liver unit. 3. Monitor for complications, including fulminant hepatic failure and encephalopathy. Signs of deterioration. 1. Low-grade encephalopathy, irritability, forgetfulness, sleep disturbance. 2. Prolonged INR. 3. hypoglycemia 4, hypolbuminemia 5, lactic acidosis treatment considerations, hematologist input for coagulopathy management, mountain daylight time decision making for timing and mode of delivery, N-acetylcysteine for non-pregnant ALF predicting deterioration, lactate 2.8 mg/dl1 combined with encephalopathy may predict deterioration or death. Anesthetic considerations for liver disease in pregnancy, pharmacokinetics and drug handling 1. Altered protein binding and impaired metabolism, excretion, prolonged drug half-lives 2. Relatively normal doses required for induction of anesthesia. Safe anesthetic agents 1. Thiopental terminated by redistribution 2. Propofol, normal pharmacokinetics in cirrhosis 3. Succinylcholine, safe, minimal prolonged neuromuscular block 4. Atracurium and cisatracurium, non-depolarizing neuromuscular blockers of choice 5. Isoflurane, sevoflurane, desflurane, and nitrous oxide, safe. Considerations for specific medications, analgesia challenges 1. Paracetamol is safe in normal doses 2. NSAIDs are contraindicated due to antiplatelet effects and renal dysfunction risk 3. Opioids may accumulate due to impaired metabolism, potentially confusing encephalopathy diagnosis 4. Remifentanil may be a suitable alternative due to its metabolism by plasma esterases. Other drugs, oxytocin, ergometrine, and carbapenem, standard doses for uterine hemorrhage control, anesthesia technique, balancing risks of general and regional techniques for operative delivery. General versus regional anesthesia 1. General anesthesia may worsen or confuse encephalopathy 2. Regional anesthesia may not be suitable due to coagulopathy 3. Regional anesthesia can cause hypotension and decrease hepatic blood flow, not contraindicated in mild or stable liver disease. Careful consideration of risks and benefits, especially with coagulopathy. Thrombolistography, TEG, may be useful for guiding blood product administration. Additional considerations 1. Intraoperative cell salvage, no contraindications specific to non-oncological liver disease 2. Infusions of propofol and fentanyl suitable for sedation in intubated patients. Physiological changes in pregnancy, neurological system MAC, progesterone, Greek letter beta, endorphins, sensitivity, opioid sedatives, LOCL, Neuraxil, enhanced IVC compression, epidural vein engorgement, epidural subarachnoid space. CSF pressure. No epidural spinal during contractions, respiratory system, physiological, anatomical changes, dyspnea, common intubation, difficult, breast, edema, smaller et. No nasal intubation, trauma, hyperventilation, tidal volume, slight resp rate, PCO2, mild alkalosis, O2 use, FRC, worse supine general anesthesia risks, difficult intubation, rapid desat, O2, FRC, keep PCO2 low. Compliance, pressure, cardiovascular system, SVR, progesterone, placental vasodilation, BP, diastolic, systolic CO, stroke volume, HR, TPR. By first trimester, heart displaced flow, murmurs, common uterine blood flow, aortocaval compression, uterus compresses, vena cava supine, diverts blood, aorta less, but placental flow, regional anesthesia worsens this, hypotension. Left tilt wedge hematology, plasma volume, dilutional anemia, hemoglobin, viscosity, platelets norm, LWBC, peak labor, protein, oncotic pressure, edema, albumin, cholinesterase, prolonged succinthomium, coagulation factors, fibrinolytic activity, hypercoagulable, thromboembolism, renal function, GFR clearance, urea, uric acid, creatinine, plasma count, gastric function, morning sickness, hyperemesis, gravidarum equals extreme. Letone, intragastric pressure, reflux, aspiration, labor, opioids, delay emptying, rapid sequence induction, third trimester, 48H postpartum, endocrine function, progesterone, main hormone, HCG sustains corpus luteum, then placenta, progesterone. Placenta also has human placental lactogen, like growth hormone, insulin resistance. Acromegaly-like changes, thyroid hypertrophy, T3/T4, but free hormone, same parathyroid hormone, serum calcium, ionized calcium, constant metabolic rate, weight, musculoskeletal system, relaxin, ligament laxity, pubic sacroiliac widening, mobility, pain, lumbar lordosis, backache, anesthesia for non-obstetric surgery during pregnancy. Overview 1. Pregnant patients may require surgery for non-obstetric conditions. 2. Incidence of non-obstetric surgery, 1 to 2%. 3. Surgery can occur during any trimester, with 42% in the first trimester, 35% in the second, and 23% in the third. Common conditions. 1. Appendicitis, most common, 1 in 1500 to 2000 pregnancies. 2. Ovarian disorders, torsion or neoplasm. 3. Trauma. Anesthetic challenges. 1. Caring for two lives, mother and fetus. 2. Understanding physiological and pharmacological adaptations to pregnancy, maternal safety and non-obstetric surgery guidelines. American College of Obstetricians and Gynecologists. 1. Indicated surgery should not be denied, regardless of trimester. 2. Elective surgery should be postponed until after delivery. 3. Non-urgent surgery, perform in the second trimester. General considerations. 4. Consider delivery by cesarean section before major surgery in third trimester. 5. Delay surgery 48 hours to allow steroid therapy for fetal lung maturation. Fetal safety in non-obstetric surgery. Potential risks. 1. Anesthetic drugs may jeopardize fetal development depending on dose, timing, and route of administration. 2. No anesthetic drug has been proven to be clearly hazardous to the human fetus. However, due to ethical concerns, no RCTs conducted. Teratogenicity concerns. 1. Background incidence of congenital anomalies, approximately 3%. 2. Physiologic derangements, hypoxemia, hypercarbia, stress, hypotension, may be teratogenic. 3. Anesthetic agents can potentially affect cellular mitosis and DNA synthesis. Specific anesthetic agents. 1. Nitrous oxide, inhibits methionine synthetase, potential teratogenic effects in high concentrations. Animal studies, high concentrations used as opposed to clinical dose. 2. Benzodiazepines, associated with cleft palate and cardiac anomalies, but recent studies counter this association. Avoided in first trimester. 3. Other anesthetic medications, barbiturates, propofol, opioids, muscle relaxants, local anesthetics, widely used with a good safety record. Timing of exposure. 1. First 15 days, all or nothing phenomenon, fetal loss or preservation. 2. Organogenesis 56 days, structural abnormalities may occur. 3. After 56 days, functional changes can occur, but structural abnormalities are rare. Decision-making, multidisciplinary approach is essential. 1. Consultations among obstetrical team, surgeon, anesthesiologist, and neonatologist are crucial. 2. Coordinate management to ensure fetal safety. Anesthesia management. Preoperative preparation. 1. Close liaison with obstetricians and neonatologists. 2. Ultrasound assessment of the fetus when delivery is anticipated. 3. Minimize fetal exposure during radiological investigations. 4. Relevant blood tests and cross-matched blood for major surgery. Evaluation and preparation. 1. Evaluate pregnant patients similarly to non-pregnant patients. 2. Consider risks of aspiration, difficult intubation, thromboembolism, and fetal well-being. 3. Standard adult fasting guidelines apply. Aspiration prophylaxis. 1. Administer H2 receptor antagonists and non-particulate antacids from 16 weeks gestation. 2. Consider additional risk factors for regurgitation and aspiration. Additional prophylaxis. 1. Antibiotic prophylaxis. Select antibiotics with good safety profile in pregnancy. 2. Glucocorticoids. Administer 24-48 hours before surgery between 24 and 34 weeks gestation to reduce perinatal morbidity mortality. 3. Thromboprophylaxis. Mechanical or pharmacologic thromboprophylaxis recommended for all pregnant patients undergoing surgery. Tocolytics. 1. No proven benefit to routine administration of prophylactic perioperative tocolytic therapy. 2. Indicated for treatment of preterm labor until resolution of underlying condition. Principles of anesthetic management. 1. Maintain normal maternal physiological function. 2. Optimize uteroplacental blood flow and oxygen delivery. 3. Avoid unwanted drug effects on the fetus. 4. Avoid stimulating the myometrium. 5. Prevent awareness during general anesthesia. 6. Use regional anesthesia when possible. Conduct of anesthesia, monitoring maternal standard ASA1, 2 and fetal monitoring which is discussed later. Additional maternal monitoring for uterine contractions. 1. Use external tocodynamometer outside surgical field. 2. Improve maternal hemodynamics with IV fluids and consider tocolytic treatment. Anesthesia technique, regional versus general anesthesia. No studies show beneficial effect of regional over general anesthesia on pregnancy outcome. Regional anesthesia, however, minimizes fetal drug exposure, simplifies airway management, and reduces blood loss. Choice of technique and drugs guided by maternal indications and surgical location. In case of maternal collapse, resuscitation based on ACLS. Follow standard protocols with 15 degrees left lateral tilt. Airway management, difficult airway, equipment should be ready. If known difficulty, awake fiber optic intubation. Otherwise 1. Pre-oxygenation with 100% oxygen for 5 minutes. Incorporated O2 consumption, Decker FRC. 2. Rapid sequence induction and intubation with cricoid pressure. 3. Agents of choice, thiopentone, 5 mg/kg, succinylcholine, 1.5 mg/kg, propofol, 2 mg/kg titrated. 4. Laryngeal mask airway. In case of failed intubation or second-generation SADs can be used in carefully selected patients. Anesthetic agents. 1. Volatile agents, decreased MAC values, uterine artery dilation, and reduced uterine tone. 2. Low concentration sevoflurane preferred. Hemodynamic management. Aortocaval compression in both GA and RA maintains stable hemodynamics. Avoid aortocaval compression using 15 degrees lateral position or uterine displacement. Maintain adequate volume status of the patient. Vasopressors, phenylephrine, maintains maternal blood flow and prevents fetal acidosis. For hypotension, maintain end-tidal CO2 levels within limits. Avoid hyperventilation, optimize oxygenation. Critical elements, avoid hypoxemia, hypotension, acidosis, and hyperventilation. Thromboprophylaxis. 1. Pregnancy is a hypercoagulable state. 2. Thromboprophylaxis essential to prevent thromboembolic complications. Fetal monitoring. 1. Monitor fetal heart rate, FHR, after 24-26 weeks gestation. 2. Intraoperative FHR monitoring requires skilled interpretation and obstetrician input. Volatiles reduce FHR variability. 3. Guidelines for fetal monitoring, individualized approach, team approach for optimal safety. Delivery considerations. 1. Consider delivery by cesarean section before major surgery in 3rd trimester. 2. Delay surgery 48 hours to allow steroid therapy for fetal lung maturation. 3. Anesthesia post-delivery tailored to surgical requirements. Extubation. 1. Extubate fully awake to minimize aspiration risk. Monitoring and postoperative care. Monitoring uterine contractions post-op and improve maternal hemodynamics with IV fluids and consider tocolytic treatment. Recovery from anesthesia. 1. Close monitoring of airway and respiratory system. 2. Most severe complications occur during emergence, extubation, or recovery. Postoperative analgesia. 1. Adequate analgesia important to reduce risk of premature labor. 2. Regional nerve or plexus blockade or epidural analgesia effective. 3. Ultrasound-guided transverse abdominis plane TAP block alternative to epidural analgesia. Pain management options. 1. Opioids can be used to control postoperative pain. 2. Paracetamol analgesic of choice for mild to moderate pain. 3. NSAIDs should be avoided, especially after 32 weeks gestation, due to risks of premature ductus arteriosus closure, oligohydramnios, and reduced fetal renal function. Specific procedures. Laparoscopy. 1. Pregnancy no longer a contraindication. 2. Indications same as for non-pregnant patients. 3. Advantages: less fetal exposure to toxic agents, smaller incisions, decreased pain. 4. Guidelines: monitor fetal and uterine status, end-tidal PCO2, and maternal arterial blood gases. Cardiac surgery. 1. Increased blood volume and cardiac output during pregnancy. 2. Surgical intervention considered for severe decompensation and correctable lesions. 3. Cardiopulmonary bypass increases perioperative risk, especially for the fetus. 4. Recommendations: use fetal monitoring and maintain high pump flow, perfusion pressure, and maternal hematocrit, 28%. Neurosurgery. 1. Increased risk of intracranial hemorrhage. Pregnancy increases the risk of intracranial hemorrhage due to hypertensive conditions. 2. Anesthetic considerations, controlled hypotension, hyperventilation, and diuresis require careful consideration to maintain uteroplacental blood flow. Controlled hypotension can be induced with high-dose volatile anesthetic, sodium nitroprusside, or nitroglycerin. Hyperventilation, extreme hyperventilation PaCO2 is less than 3.3 kPa, can cause uterine artery vasoconstriction and hence decreased UBF. Diuresis, osmotic agents or loop diuretics can cause significant negative fluid shifts for the fetus. 3. Fetal monitoring, essential during neurosurgery to alert the anesthesiologist to compromises in fetal condition. Fetal surgery is performed in select cases to treat life-threatening or serious congenital conditions in utero. It is limited to specialist tertiary centers. Key points include types of fetal surgery, minimally invasive procedures, mid-gestation open surgeries, exit, ex utero intrapartum treatment, procedures, goals and challenges for the anesthetist. Preventing preterm labor, maintaining maternal homeostasis, especially with the use of tocolytics, preserving fetal homeostasis during surgery, providing adequate fetal analgesia. Current considerations. Open procedures are associated with risks like preterm labor and membrane rupture, prompting a shift toward minimal access techniques. These procedures remain rare and are typically not encountered in routine obstetric anesthesia practice. Here's a streamlined version of your analgesia for labor section. Analgesia for labor: commonly used methods: inhaled nitrous oxide, N2O, opioids, and central neuraxial blockade CNB techniques, epidurals, spinals, and combined spinal, epidurals. Non-pharmacological options: techniques like childbirth preparation, massage, acupuncture, warm baths, and TENS may offer support, though evidence for pain relief is limited. Nitrous oxide, Entonox registered sign, widely used, safer and more effective than a single dose of pethidine but doesn't provide complete analgesia. Can cause nausea and presyncope. Prolonged use affects hematological and immune systems. Also a potent greenhouse gas. Opioids. Pethidine is commonly used but has drawbacks: long fetal half-life 18-23 HRS, reduced fetal HR variability, neonatal neurobehavioral effects, and potential breastfeeding issues. Alternatives: IVPCA with fentanyl or remifentanil, and IM diamorphine, used in the UK, though may prolong labor. Central neuraxial block CNB, most effective form of labor analgesia, effective in over 85% of women. Blocks uterine pain and vaginal pain. Paracervical and pudendal blocks are less effective and largely outdated. Associated with hypotension, increased oxytocin use, and maternal pyrexia, but not higher CS rates. Low-dose epidurals, 0.1% bupivacaine, do not increase instrumental delivery rates and may improve fetal umbilical pH. Optimizing CNB, use low-dose LA with opioids to reduce motor block and hypotension while improving satisfaction, 0.0625%, 0.125%. Walking epidurals maintain analgesia using patient-controlled epidural analgesia, PCEA. Delivers the lowest total LA dose. Intermittent top-ups, lower total LA dose than continuous infusions. Continuous infusions deliver the highest total LA dose. Epidural analgesia for labor preparation. Ensure a trained midwife is available for one-to-one care. Establish IV access. Fluid loading is unnecessary if low-dose LA is used and there's no hemorrhage dehydration. Use sterile technique, mask, hat, gown, gloves. Position patient sitting or in full lateral sitting may aid midline identification. Record fetal heart rate before and during epidural insertion. Skin preparation: use 0.5% chlorhexidine, let it dry before contact. Avoid contaminating CNB equipment or gloves. Unwrap equipment after sterilization. Epidural insertion: locate the epidural space using a 2E needle. Loss of resistance to saline may lower the risk of dural puncture. Inject 10 ml saline before threading catheter to reduce vessel puncture risk. Thread catheter 3.5 to 5 cm into epidural space, too long, unilateral block, too short, dislodgement. Aspirate catheter for blood or CSF. If blood is aspirated, reposition or replace catheter. Test dose and loading: give a test dose, e.g., 2 -5 ml of 2% lidocaine or 8 ml of 0.1% bupivacaine plus 2 mcg ml fentanyl. Load after 5 minutes with 12 milliliters of the same solution. Absence of block suggests malposition. Every dose is a test dose. Monitor BP every 5 minutes for 20 minutes after each bolus. Maintenance options PCEA, e.g., 5-10 ml boluses of 0.1% bupivacaine plus 2 mcg ml fentanyl, with 15 to 20 minutes lockout. Continuous infusion. 5-12 ml H of same solution. Intermittent midwife top-ups, rare in UK. Programmed intermittent boluses, reduced breakthrough pain versus continuous infusion, no increased instrumental delivery risk. Combined spinal epidural CSE analgesia for labor. Key features: combines low-dose subarachnoid LA and/or opioid with epidural top-ups. Provides rapid onset of analgesia, 10 to 15 minutes faster than epidural alone. Minimizes motor block, useful for patients unable to stay still due to pain or after a failed epidural. Some evidence suggests improved epidural efficacy after spinal effects wear off. Used routinely in some centers. Techniques: 1. Needle through needle. Identify epidural space, L3/4 or below, with 2E needle. Insert 25-27G pencil point spinal needle through 2E. Inject intrathecal dose, e.g., 0.5 to 1.0 milliliters of 0.25% bupivacaine plus 5-25 mcg fentanyl. Insert epidural catheter without rotating the 2E. 2. Separate injection. Perform spinal. Inject same subarachnoid dose. Place epidural catheter at a different interspace. Useful when patient is too distressed to tolerate epidural initially. Post-procedural steps: check sensory and motor block after 15 minutes. Give epidural test dose. Watch for changes within 5 minutes to rule out intrathecal placement. Continue maintenance as per standard epidural protocol. Dural puncture epidural DPE. Modified technique using a 25G pencil point spinal needle, but no intrathecal injection. Follow with standard epidural placement. Provides slightly faster and improved analgesia compared to epidural alone. Lower incidence of hypotension, pruritus, and uterine hyperstimulation than CSE, likely due to small CSF leak-enhancing drug spread. Complications of CNB analgesia: 25% of laboring women in the UK receive epidurals. Obstetric patients account for 45% of all CNBs. Long-term complications are rare due to shorter duration and healthier patient population. 1. Hypotension common after CNB anesthesia, less so after CNB analgesia. Maintain SBP, 90% of baseline to preserve uterine perfusion, not auto-regulated. Fluid loading not needed with low-dose LA unless hypovolemia suspected. Management: position patient laterally or upright, avoid aortocaval compression. IV fluid bolus, crystalloid. Vasopressor, e.g., 6 mg ephedrine IV, repeat if needed. Call obstetrician if fetal distress. Give oxygen via face mask. Treat for hypotension if fetal distress follows CNB, even without hypotension on monitor. 2. Subdural block incidence 1/1000, hard to distinguish from epidural block. Diagnosis is clinical or radiologic. L features: slow onset 20 to 30 minutes, excessive block height, may reach cervical dermatomes. Patchy, asymmetric block, may spare lower limb motor fibers. Risk of total spinal with top-ups. Action: suspect and resite catheter if suspected. 3. Total spinal leading cause of maternal cardiac arrest in UK delivery units. Risk increased if spinal follows a partially working epidural or with catheter misplacement. Progression of symptoms: 1. Difficulty coughing. 2. Weakness in arms, hands. 3. Difficulty speaking, breathing, swallowing. 4. Loss of consciousness if rapidly rising block, head up tilt for hyperbaric LA or excess epidural dose. For plain, hypobaric LA, use gentle left lateral position, avoid head up, avoid sudden movements, can worsen block. Management: have airway ventilation equipment ready. Call for help, follow ABC approach. Support airway, breathing, circulation. Avoid aortocaval compression. Intubate if necessary, often with a reduced induction dose. Monitor mother and fetus closely, CS only if fetal distress present. Ventilate for 1 to 2 hours, extubate after hand grip strength returns. Dural puncture and postdural puncture headache. PDPH. Pathophysiology: CSF loss from a dural tear reduces CSF pressure, brain sags, meningeal traction, headache. Neck stiffness, Cranial nerve involvement. Compensatory vasodilation may worsen symptoms, causes and incidence intentional, spinal anesthesia or combined spinal epidural CSE. Unintentional, complication during epidural insertion, 1% of epidurals, up to 40% unrecognized 16G2E needle PDPH risk, 50%, 25G pencil point spinal needle PDPH risk 2 to 10%. Severe PDPH needing blood patch, 1 in 10 among spinal recipients. Onset, usually 24 to 48H, but up to 5 days. Dural puncture. Immediate management of accidental dural puncture. 1. Inform the patient and document clearly. 2. Daily anesthetic review until resolved. Options: intrathecal catheter, leave catheter in situ 2 to 3 centimeters, label clearly. Use intermittent small doses, e.g., bupivacaine plus or minus fentanyl. Prevents repuncture, may reduce blood patch need. Risks: tachyphylaxis, catheter dislodgement, mistaken identity. New epidural, reinsert 1 space higher. Cautious dosing, risk of high block from dural leak. Clinical features of PDPH: positional headache, worse on standing, better lying down, but not always postural. Fronto-occipital pain plus or minus neck stiffness, photophobia, visual or auditory symptoms, cranial nerve palsies, ESP, CN6, tinnitus, diplopia indicate severe PDPH, may be life-threatening, risk of subdural hematoma, venous thrombosis, brainstem herniation, rare. Treatment of PDPH: conservative, bed rest, short-term relief. Consider VTE prophylaxis if immobile. 24H. Hydration, encourage, but excessive fluids may be harmful. Simple analgesics, limited relief. Caffeine, up to 900 mg day, 200 mg max if breastfeeding, modest benefit, risk of seizures at high dose. Definitive, epidural blood patch, EBP, most effective treatment. Indicated for severe symptoms, cranial nerve palsies, or unresolved headache. Not routinely recommended, due to limited evidence. Nerve blocks, steroids, ACDH, gabapentin, acupuncture, epidural opioids, fluids. Prophylactic EBP is not advised post-delivery due to high bacteremia risk and poor efficacy. Epidural blood patch, EBP, indications. Definitive treatment for post-dural puncture headache PDPH. Considered when 1. Conservative measures fail, or 2. Headache is severe, persistent, or associated with cranial nerve signs. Efficacy: only 33% have complete resolution, 50 to 80% report partial benefit. Relapse is common, repeat EBP may be required. Lower success if EBP done, 48H after dural puncture. Mechanism of action: 1. Immediate relief. Epidural blood compresses the thecal sac, raises intracranial pressure (ICP), alleviating symptoms. 2. Long-term effect. Blood clots over the dural tear, seals the leak, allowing CSF refilling. Common complications: backache. 35% at 48H versus 16% may experience prolonged pain, mean 27 days. Others, rare, repeat dural puncture. Neurological deficits, arachnoiditis, infection, seizures, cranial nerve damage. Pre-procedure requirements: written consent including partial success rate and possibility of repeat procedure. Common back pain and rare but serious complications. Patient must be apirexal with normal WCC. 2 operators required. 1. Experienced epiduralist. 2. Sterile blood draw assistant. Technique: step by step. 1. Pre-procedure bed rest may help reduce CSF volume. 2. Use strict asepsis at both sites, epidural and venipuncture. 3. Position, left lateral, reduces CSF pressure in lumbar sac. 4. Epidural insertion at same or lower interspace than the dural puncture. 5. Draw 20 ml autologous blood. 6. Slow injection into the epidural space. Stop if pain, typically in back or legs. If pain resolves, resume slowly. If it recurs, abort injection. 7. Post-injection care. 2 hours bed rest. Allow clot formation. Avoid straining, lifting, bending for 48H. Post-procedure instructions provide clear follow-up guidance. Recontact anesthetist if symptoms recur. Cardiac disease in pregnancy. Key points. Cardiac disease is a leading cause of maternal mortality in the UK. Maternal death due to ischemic heart disease is increasing in the developed world. Rheumatic heart disease is the leading cause of maternal heart disease in the developing world. Some conditions still have such a high maternal mortality rate that fetal termination is advised. Low-dose epidural infusion for labor with assisted second stage is suitable management in many cases. Oxytocin can cause hemodynamic instability and should be used with care in mothers with cardiac disease. Cardiac risks in pregnancy. Women with pre-existing heart disease face increased risks during pregnancy. Key risk factors for cardiac events include 1. Prior cardiac event. 2. Poor NIHA functional class or cyanosis. 3. Left heart obstruction. 4. Systemic ventricular dysfunction. Cardiac events can include pulmonary edema, arrhythmia, cerebrovascular events, cardiac arrest, or death. The risk of cardiac events correlates with the number of risk factors. 0 risk factors, 5% risk. 1 risk factor, 27% risk. 2 or more risk factors, 75% risk. NIHA functional classes. Class 1, no limitation, no symptoms. Class 2, slight limitation, minimal symptoms. Class 3, marked limitation, moderate symptoms. Class 4, severe limitation, symptoms at rest. 1. Rheumatic fever is prevalent in developing countries, causing valvular heart disease in women of childbearing age. 2. Women with cardiac disease need preconception or early pregnancy counseling on risks. 3. Certain conditions, e.g., pulmonary hypertension, may warrant termination due to high maternal mortality risk. 4. Management should occur in specialist centers with a multidisciplinary team. 5. Suspicious signs for cardiac disease in pregnancy: loud fourth heart sound, diastolic murmur grade 3/6, systolic murmur, fixed splitting of second heart sound, opening snap. Investigate with ECG and Rheumatic fever is prevalent in developing countries, causing valvular heart disease in women of childbearing age. 2. Women with cardiac disease need preconception or early pregnancy counseling on risks. 3. Certain conditions, e.g., pulmonary hypertension, may warrant termination due to high maternal mortality risk. 4. Management should occur in specialist centers with a multidisciplinary team. 5. Suspicious signs for cardiac disease in pregnancy: loud fourth heart sound, diastolic murmur grade 3/6, systolic murmur, fixed splitting of second heart sound, opening snap. Investigate with ECG and echocardiography. Physiological changes in pregnancy and labor. 1. Cardiac changes: cardiac output increases by 40% by 20th week due to increased SV and HR. Blood volume increases by up to 50%. Systemic vascular resistance, SVR, falls. 2. Impact on heart: additional strain on a failing heart. Increased right to left shunting, reducing pulmonary perfusion and potentially causing hypoxia. Physiological and labor-related changes in pregnancy. Physiological changes in pregnancy: by 20 weeks, cardiac output by 40% due to increased stroke volume and heart rate. Blood volume by up to 50%, but SVR falls, increasing cardiac workload. In patients with shunts, reduced SVR can right to left shunting, decreasing pulmonary perfusion and worsening hypoxia. Combined with increased oxygen demand, this may lead to progressive desaturation. Labor and delivery: labor imposes additional hemodynamic stress. Pain-induced tachycardia reduces diastolic filling and catecholamines, raising SVR. Autotransfusion during contractions shifts 500 milliliters blood into circulation. Cardiac output: Valsalva during pushing may cause hemodynamic compromise. Peripartum risks: bleeding risk with anticoagulation. Blood loss poorly tolerated due to limited compensatory mechanisms. HRSV. Pulmonary edema risk due to fluid shifts, excess IV fluids. Cardiac dysfunction: use concentrated infusions in small volumes. Arrhythmias and tachycardia poorly tolerated. Avoid drugs like oxytocin, ephedrine. Prefer alpha agonists, phenylephrine, metaraminol. Reduced SVR, e.g., from regional anesthesia, may be harmful in fixed CO states, e.g., severe as shunts, right to left shunting. Pulmonary flow, hypoxia, high VTE risk. Use TEDs, prophylactic heparin. Air embolism risk in RL shunts. Use meticulous IV technique. Acute pulmonary hypertension can cause RV failure and ischemia. High mortality with severe PHT, but significant morbidity even with mild pulm HTN. Postpartum care: monitor closely for 72 hours postpartum, especially with pulmonary hypertension. Most deaths occur after delivery. Maintain strict fluid balance. Re-establish anticoagulation if needed. Ensure effective analgesia to prevent tachycardia and catecholamine surge. Cardiac function returns to baseline over 6-8 weeks. Cardiac lesion risk stratification: low risk mortality 0.1 to 1%. Repaired lesions: uncomplicated LR shunts, mitral valve prolapse, bicuspid aortic valve, aortic mitral regurgitation, pulmonary stenosis regurgitation. Intermediate risk mortality 1 to 5%. Mechanical valve, single ventricle, systemic right ventricle, unrepaired cyanotic lesions, mitral stenosis, mild moderate aortic stenosis, severe pulmonary stenosis. High risk mortality 5 to 50%. NIHA 3/IV or symptomatic preconception, severe 55 dysfunction, severe aortic stenosis, orphans with aortic valve lesion, dilation, pulmonary hypertension, congenital and acquired valvular heart disease in pregnancy. Valvular heart disease in pregnancy. General points: valvular lesions often unmasked by pregnancy. Regurgitant lesions better tolerated than stenotic lesions due to SVR forward flow. Carefully titrated epidural is safe in most regurgitant lesions. Aortic stenosis as severity indicators: valve area 0.5 centimeters to the power of 2, gradient 60 mmHg, mortality up to 5% if severe physiological concerns. Fixed CO cannot increase with demand and SVR, poorly tolerated hypotension, diastolic pressure, coronary perfusion 55, ischemia, tachycardia, bradycardia, hypovolemia, IVC compression. All poorly tolerated. Monitoring and management: invasive BP monitoring essential in severe as alpha agonists, phenylephrine, metaraminol, preferred. Avoid ephedrine beta-1 stimulation. Tachycardia. Anesthetic approach: GA may be required in unstable severe cases. Regional anesthesia possible with careful technique. Gradual epidural, top-up low dose CSE spinal catheter for slow titration. Emergency measures: acute decompensation, may need aortic valve replacement. Tertiary center with cardiac surgery backup. Essential mitral stenosis, MS severe. Valve area 1 cm to the power of 2 on echo. Pathophysiology: LA pressure, pulmonary congestion.